Greetings, everybody, on behalf of Bombay Orthopaedic Association. Bombay Orthopaedic Association is one of the oldest associations in India, and WIROC is its annual conference. WIROC Global is the 56th annual conference of BOS, and this year we have invited societies across the globe, and we are glad to share that more than 70 societies are participating in WIROC Global. We sincerely thank SICOT for participating in WIROC Global on behalf of my president, Dr. Sangeet Gawale, and Dr. Vishal Kundani, who is my co-organizing secretary, and the entire BOS Executive Council. We welcome you again and thank you for your participation.
Greetings and welcome everyone who's on this SICOT WIROC Symposium on Trauma and on recent advances in implantology, a very, very important topic. Well, I am greeting you from Mumbai, the place where WIROC Global is happening. And it's a very exciting event. SICOT is participating in it, and I thought I would tell you something about SICOT. I know that a lot of you would be aware about SICOT, and I did not talk much. But then amongst your group are also people who are new, who are young orthopedic surgeons, and who may not be very familiar. And hence I want to speak a few slides about SICOT, its vision and mission. So at the turn of the 20th century, a lot of prominent orthopedic surgeons got together with the idea of founding an international body dealing with orthopedics, and all these famous surgeons actually came together on 10th October 1929 to form SICO and then SICOT. Now the objectives, the vision was to promote the advancement of the science and art of orthopedics and traumatology at an international level, in particular for the improvement of patient care, to foster and develop teaching, research, and education, and to promote friendship and camaraderie amongst its members with the above aims in mind. So SICOT is the foremost international organization in orthopedics, representing 110 countries and thousands of members. I have been privileged to be the president of SICOT, and very soon we are going to move on to the 100th year of SICOT. That's going to be a real big jump for an orthopedic organization to last 100 years. It has to be meaningful. So then, what is the mission of SICOT? Well, the strength of SICOT is its international penetration. It has been innovating education and training. The most recent example is the SICOT Pioneer innovative program of webinars and e-learning. Then there are regional SICOT educational programs being conducted by different branches of SICOT all over the world. Skills development, knowledge, and the diploma SICOT examination. Trainees have their programs and fellowships, and SICOT probably has the highest number of international fellowships for its members across the world. Now, recently, we formed the board of subspecialties, and a specialty thrust has been given through BOSS. So there will be specialty courses and CME programs. Of course, we've been doing our world congresses from the beginning of SICOT. Research Academy brings about a lot of awareness about research, research awards and research grants. We have publications like the SICOT newsletter, the OpenSS SICOT journal, and the very famous International Orthopaedics. And then financial allocations are made for different programs, for example, for the different education centers around the world. So this is SICOT having an international penetration, more than 100 countries. It runs educational centers in numerous parts of the world, and this is from Africa. This is actually from Egypt, about SICOT fellowships in Africa. And 15 years of training, 82 fellows from African countries were trained in the orthopedic department of Asyut University in Egypt since 2002. and they have a very extensive training program. So this is a post-SICOT fellowship evaluation report. And then on merit, based on the examination, diploma examination, we have some fellowships, for example, the SICOT, German traveling fellowships. There are some other fellowships to be given out to the top candidates who score the best in the diploma SICOT examination. Now, this is a trainees meeting, a SICOT international trainees meeting, where trainees can actually speak and where trainees interact with their senior colleagues. So this is a report of the SICOT Egyptian Orthopaedic Association Trainees Day, which was held 2011. This is the old report from the newsletter, SICOT newsletter. The diploma SICOT activity has been in existence ever since it started in 2003. Because of COVID, we've not had exam for the last 2 years, but they're very much there in the Kuala Lumpur meeting this year. The World Congresses, and we organized the World Congress in India in 2013. Well, it's a beautiful meeting place for colleagues from all over the world, where you can have formal as well as informal interactions and collaborations are possible throughout the world on such meetings. That's the reason I wrote this editorial, Global Orthopedics, SICOT, the great leveler. Of course, this is again an old newsletter, but the essence of SICOT is cooperation, collaboration, and innovation. So come, join us. For those who are not members of SICOT, please join us. It will really be worthwhile for your orthopedic careers. And you can find more information on www.sicot.org. Thank you. And I hope you enjoyed the session very much. Goodbye.
With this, I hand it over to Dr. Arindam, who is the convener of SICOT session for WIROC. Over to you, sir.
Thank you very much, Ashok. And we are very happy to participate with WIROC, which we know is a very, very dynamic organization. And this is part of our symposium on orthopedic trauma implantology. We're going to have a couple of panel discussions. The first panel discussion is going to be moderated by Roman Pfeiffer from Switzerland, and he has his 4 panelists. The rest of it is going to be on lower limb orthopedic implantology, and those of us who are in the upper limb team, we will make ourselves mute right now, and we will not be on the. We will stay on the screen, but without turn our cameras off. So we look forward to an interesting session, a good discussion, and I hand it over to Roman.
Thank you very much. My name is Roman Pfeiffer. I'm from the Department of Trauma Surgery at University of Zurich in Switzerland. And I would like to welcome our 4 panelists. It's Professor Alvaro Zamorano from Chile and South America. We have Professor Shetty from India, Professor Gadegone from India. Welcome, thank you very much. And we have Professor Niikura from Japan. I think is I can say the panelists are from all over the world and have a lot of experience. And I would like to just start with one case at first. And probably we can discuss with you about aspects, what you feel important in such fractures, in such treatment, and probably implants that might be relevant. And in the end, we will see what we can. Just give me a second to start it. So can you see my presentation?
Yes, sir.
So thank you very much again to have the opportunity here to discuss with you such interesting cases. And I already have introduced all these panelists. So I have no conflict of interest. And I would like to discuss with you about multi-level fractures of the femur. So usually these fractures are associated with a high energy trauma, with polytrauma, and the surgical management is not so easy, and very complex, and very often you have like combined fractures, or like here additional proximal fractures in the femur, like it's shown here. And you have floating parts which also need to be fixed. And according to the literature, please correct me if you know something, but there are no clear treatment algorithms. So the question is, the question is to all panelists, what are your strategies in such cases? This is he's a young man, he's around about 30 years old. He had a car accident with a high energy trauma with bilateral femoral fracture on both sides. And you see the proximal femoral fracture is the femoral neck. So what do you think about this injury type? And what would you suggest how to approach such fractures on the treatment? So anyone who wants to start?
Yeah, can I?
Of course, Professor Shetty.
Here is a situation that his general condition has to be looked into. And once he's revived and is good for surgery, it has to be fixed. And I would prefer an intramedullary nail for the right side, and for the as far as the fracture neck of the femur and the lower third fracture. And FNS, it is a vertical fracture, vertical shear fracture. It is a Powell's 3. So that has to be impacted. That I would prefer a synthesis FNS system for the proximal femur, and for this a retrograde nailing on the right on the side of the fracture. Whereas for the right side also, if it is because it is a lower third fracture, a retrograde nail would be much better, or a system where either the Cyrus nail, where there is an anterior-posterior and a medial-lateral screw is there, so that the rotational strain will not take place at the right side also. These are the possibilities.
So, Professor, what do you think if this patient would be not so stable and you need to do a damage control approach?
Yes, if it is no, that's why I started with the if he is revived and his general condition is good, we always believe the early total care, or whether it is a damage control, or in between early appropriate care. If it is early appropriate care, there is no, all the 3 fractures can be fixed simultaneously if the condition is good. Otherwise, a damage control has to be taken into consideration.
But what do you mean with damage control? Do you mean just external fixation of the shaft? What would you do with a femoral neck fracture?
That's why I said early appropriate care. Early appropriate care is for the right femur, an early appropriate care, and perhaps an external fixator for the right for the left side. But I wouldn't like it because there is a fracture neck of the femur. That's why I said it is better to revive. And all the studies now have proved that for the fracture neck of the femur, time factor is not a very important factor. If the patient is revived well, it can be done even after 2 or 3 days.
Okay. Are there any other opinions from the panelists?
Actually, there are 2 parts of the fractures. May I?
Of course, yeah.
There is a bilateral injury, ipsilateral fracture neck with shaft, and here is the trochanter with shaft. So after a stabilization of this patient, because this patient likely to go in ARDS and pulmonary embolism, high chances. And therefore, if the patient is stable, and then we have to go for the definitive treatment. Otherwise, we will have to plan for external fixator for some time and then do. But here the priority is of the fracture neck of the femur on both sides, because it is intercervicobasal on the left side, right side it is a vertical fracture neck of the femur. So I will try to do first the fixation of the neck of the femur, but that is so important, and probably I may do it with the DHS and derotation screw which is available with me, and it is a vertical fracture. Probably I may add a perpendicular lasso type of the screw on a vertical type of a fracture, and a multi-locking supracondylar nail for a femoral fracture. That is my plan of treatment. Both side DHS with multi-locking supracondylar nail through the knee joint for both the fractures, on right as well as on the left.
Professor, what kind of, would you put the patient on the extension table for reposition? Or what kind of reposition would you do? It would be an open procedure, is extension table for nailing, or what is your approach in such situations?
Actually, for supracondylar nailing, probably we require a simple table with the flexion of the knee. Therefore, we can fix first the femoral shaft fracture, and in the same sitting, after fixing the supracondylar fracture, we shift to the on fracture table and do for a neck femur fracture. That can be done.
Ah, interestingly.
Yes. Yes.
Comment?
If I can something, it's I absolutely agree with the both prior panelists. I think it's the priority is the femoral neck fracture, and we also use an extension table. We probably open the proximal femoral fracture in for anatomical reduction, and also we go for retrograde nails. I don't think it's necessary absolutely supracondylar nail that implants are sufficient screws in the distal part to maintain stability, but I think it's more distal shaft fracture. A common regularly retrograde nail can do the work.
Okay, thank you very much. Just move on with our discussion, and there are different strategies. What I have found, so similar to similar fractures. This is again like a femoral shaft fracture with additional petrochondritic fracture here on the right side. And the one idea would be to use here, for example, such a cephalomedular implant or this is gamma nail. And we feel it's a reposition time. It's very reposition time is too long on operation time. It's very difficult in such fracture types, and especially this intermediate fragment here is very often unstable. So so it leading to such as we call it like a floating part, which leads to a pseudarthrosis in this area. And sorry again, this is another way what can be used here with the plates. For example, we have DHS and additional plating, but the risk here to have a kissing implants with stress risers is also very high. So the question is whether there's a plating with such a severe soft tissue damage here or soft tissue manipulations, whether it would be also a strategy. Is there any opinions to it? So would rather someone of you do more plating or more nailing in such situations, or what are the ideas behind such strategies?
May I?
Of course, yes, Professor.
Actually, in such a devastating injury and soft tissue problem deglowing internal, better the plating and open reduction should be discouraged, because the fracture shaft femur, if it is aligned by closed method, it heals better way. Anatomical restoration by plate and such a distraction at the fracture site, it is going to fail even after doing a 4 and 4 screws, and they are very near screws. There is a very this working length is very also short. DHS and additional screw, it has been done very nicely, and probably it will heal because there is a cortical contact of the bone to bone and sentence line is also restored. But I am worried about the femoral fracture. It is a incipient future failure of a femoral fracture.
Yes, it's very important to keep in mind that there is two kind of different fracture in the same bone. So both fractures have different mechanical demands. So in the proximal part, we have to achieve optimal reduction. You can fix with screws, or depend of the vertical shear fracture line. You can use FNS or DHS with anti-rotation screw. But for shaft fracture, it's really difficult to the goal in the shaft fracture is alignment, rotation, and length. So it's two different things. So one implant is really difficult to achieve both objectives with one implant. So for me, it's two implants, two different fractures, step by step, and the best implant for any mechanical demands of the fracture.
So Professor Zamorano, so you would rather suggest to use nails in such situation if you have multi-level fractures, not plates like it's shown here on the right side?
Yes.
Can I?
Of course, sorry.
As Dr. Vasudev rightly mentioned, plate for injury of this nature should be discarded, as I feel. Not only this fracture is fixed with a little distraction, but then opening the fracture at this stage and fixing it with the plate is hazardous. So it should be a retrograde nail could have been done. And nowadays you get even a very good nail by the Synthes retrograde nails, which are RAFN, which really fits in very well, and it can go right. And your DHS has been done very well with that, but the derotation screw I would put it a little shorter to be in line with or a little lower. That would have been ideal. And as you rightly said, the stress razor between the two implants here is a problem, and there can be a problem later.
But that problem can be solved after if the fracture is united. Early removal of one of the implant is necessary to prevent a further fracture in the gap. So that can be that issue can be addressed later on. But first is the prime is or union at both the side of the fracture, that is more important.
Thank you. So I move on. Just I'd like to tell you what we did with this patient. You again see on the left side, this is a patient with a bilaterofemoral fracture and this femoral neck fracture. At first, we did a damage control approach and stabilize the both femoral components here with the external fixation and add here and DHS on the left side. After the stabilization of the patient, like you see, we performed the retrograde nailing. Here's the wire, and we have shortened here the screws and performed reaming like a standard. And after that, position the nail like it showed here, and try to find like a hole or a leg screw where we can position to stabilize the whole construct with DHS and the nail. So this is like a final result of this osteosynthesis. So what do you think? Is there any comments, improvements, or ideas what else can be done?
This is a nicely done surgery, and I think all issues are addressed with this nail length, as well as there is overlapping of the implant, which also prevents a stress riser. But there is only one concern, why I should say that the distal locking screws of the femoral nail, they are uniplanar, they are medial to lateral. If you add one or the two oblique screws, then it becomes a rigid construct, because one sided mediolateral screws in such a distal fragment, there is just some translation and varus angulation may occur. And in this case, the fracture started uniting, but you may get some problem. Therefore, the multi-locking nail with two mediolateral and at least two oblique screw would have been better implant of choice. And the technical wise, this is the perfectly done, sir.
Thank you. Any other comments, ideas?
Nicola from Japan. This fixation is very nice, and I agree to the Dr. Gardegon. It's better that the nail has multi-directional screws, so not unidirectional screws. So, for example, AP and ML or oblique screws. So multi-directional screws in the nail is better, I think.
Okay, just would like to show you another cases, similar cases. So this is again a femoral shaft fracture with a multi-level, and here a floating fragment in between these proximal distal fragments. And again, we perform here an anterior nailing with additional axillary screw here with a cortical screws here to fix the rotational fragment. So is it something what can be done? It's shown here, or is it something probably what's not so useful? What do you think?
It's, in my opinion, it's a nice strategy to avoid rotation and to control these uncontrollable fragments. The segment maybe get a really nice cortice with a uniplanar plate. So it's, in my opinion, and it's a great tool to use. And the different thing, maybe I do retrograde nail because I think is the distal part is more important to controlling the coronal plane. So I prefer to use a retrograde nail, but for me, unicortical plates are a great tool to use in those kind of situations.
Yeah.
Perfect.
Can I? The augmentation plates in the lower third or lower fourth femur fracture is well known now. And the augmentation plate is, your nailing has been perfect, but the augmentation plate, we put at least 2 screws onto the opposite cortex. But you have 3 screws distally, so that should look after that. But still, if 2 screws are in an augmentation plate, the problem is the torsional strain which takes place because of the large medullary cavity. So an augmentation plate, to really control it, I feel it has to go to the opposite cortex, at least 2 screws, so that it will stabilize itself.
May I?
Of course, yes.
I totally agree with the Shantaram Shetty sir, because this plate, actually the nailing has been done perfectly. There is no doubt about it. I would have preferred a multi-locking retrograde nail, but the plate is a concern here because we have used only there are 3 screws inside. But if there is a concern about the plate is very small, and you will find that the lower part is mostly a cancellous part, and a unicortical screw in a cancellous part, they doomed to fail if there is a varus strain. Upper part, I would have preferred a long plate which is coming to the condylary area so that it spans over it, and it's just a stabilizing plate, not just an augmented plate, and not a very small screws near the fracture site. So 2 to 3 screws at the condylar level and 1 or 2 screws in the diaphysis, even crossing that second fracture also would have been done by me. So now there is a problem. Suppose rotational stresses are more, and if the patient is younger, then probably you may get some loosening of the screw in a distal part of the plate. That is my.
Thank you very much for your opinion. So I have another very small cases again, but have similar strategies. Again, there was one patient with a femoral fracture. He is a multi-level fracture, and then he is in floating part, and the lateral femoral neck fracture. It was stabilized with a DHS retrograde nailing and additional screw. So what do you think? Is it? What is your opinion regarding it? So you have 3 fractures now here: lateral femoral neck and floating parts. Is it something what can be done, or would you suggest something different to treat such multi-level fractures?
Can it be no, it will be a difficult proposition. If at all, if your guide wire comes through, we can try a single implant. And then if it fails, then you can go ahead and do a procedure which you are undertaken. This is really very well done, but it takes a longer time and it takes a lot of energy, and it is too many implants in the bone.
So what would you idea? What would you suggestion?
A single nail through and through, and a Cyrus nail-like thing, which has an anteroposterior screw also distally, and it goes through the neck as well, if the reduction comes through. If the guide wire you are able to pass through a single implant, that is the alternative. It is not, I won't say it is the best, but if it is to save time, and if it is this thing, if your reduction, because it is multi-segmental, it may be difficult. I won't like to open the fracture here. So anyway, for your augmentation plate, you have open the fracture site.
Yeah, everyone here, we deal with those kind of fractures, and we know that it's really difficult to achieve that kind of reduction to promote healing. So in my opinion, I think one implant could be not so, the mechanical demands of this fracture are both different. So I use always 2 implants for that kind of situation.
Sir, may I ask one question?
Of course, yes.
What is that? Is in the second X-ray, it was just a cervicobasal extending into the trochanter fracture. You used the additional plate, and there is a size. I think it's a circulage wire also.
You mean on the right side, on the left side? Here,
here. On that, where additional plate is there, that is single implant gamma nail. Yes, and there is an additional plate you can see here. And you have also used a circulage wire. The forward circulage wire is there, and if you see very carefully, you will find that the calcar is going into the lesser trochanter inside. So it is a negative cortical support because of your circulage wire tightening. So it is worthwhile to see the follow-up of this patient.
Okay. Colleagues, I mean, very short question that's for me or for surgeons, probably which are not so experienced in such a complex situation. How would you start? I mean, for me, it's sometimes very difficult to understand, to plan it and to say which fracture I start to fix first, and what kind of extension tables, or do I need a supine position, lateral position? I mean, it's such a complex situation. What is the best way to reduce such fracture? Can you comment it?
Can I?
Yes, of course.
Yeah. Now, as far as the right side fracture is concerned, which are fixed with a retrograde nail and a GHS, your fracture femur has to be fixed first, and you need not put on a table. You just retrograde. You fix those 2 fractures. Then you can fix the DHS and put him on the table under traction and putting. So the fracture femur has to be fixed first.
Okay.
For me, it's different because when you tap forward, if you not have any containing the femoral proximal femoral zone, you can tap, and you cannot finish. So in my opinion, maybe a temporary X-fix to maintain the shaft stable, and first the proximal femoral fracture, and then a retrograde nail as you show here.
May I?
Yes, Professor, yes.
When you start do the surgery of a supracondylar nail and shaft fracture, if you want to do it first we have to temporarily fix the neck fragment in anatomical position, because it is mostly undisplaced fracture. So as soon as you take the patient on table, it is always mandatory to put a 3-4 mm Steinmann pincer like that, so that they will fix the fracture fragment. And when you do a manipulation, everything of a supracondylar fracture, that fracture should not get displaced. That is the precaution we have to take. Otherwise, as my friend said, that you do a X-fix for some time, temporary region, fix first the neck fracture fragment because it's a priority, and then you can do a supracondylar nailing in a 1 or 2 days afterwards. But in a single implant, if you want to do it, one of the fracture may need a open reduction because excessive manipulation will displace one of the fractures from its position. Therefore, it is not always a closed procedure. Sometimes or many times, depending on the accuracy of a surgeon's and its competence, may require one of the fracture a open reduction.
I prefer to fix the neck first because I want to fix the neck fragment as soon as possible. So I agree with Dr. Zamorano. I use external fixation for shaft fragments, and I use fracture table and fix the neck fragment with DHS.
Okay, thank you very much.
Our only concern is if you fix the fracture, this is a fairly stable situation of the neck. It is not a classical neck fracture. It is passing through the trochanter. It is coming down the trochanter line, which is stable. Once you fix the distal fragment, automatically once you give the traction, that fracture becomes stable. Unlike a vertical fracture of a fracture neck of femur, which is at the neck, so that is the difference between this fracture and a classical neck fracture. That's why we emphasize fixing both can be done, but we thought that would be the argument for our proposition.
Actually, the decision should be taken on table. If there is an undisplaced fracture, go for the fixation of that particular fracture, and if the manipulation, you go for next. So whatever it may be, you have to change and prepare for both the situation. And that is how it is. Whether you can conclude with the final or you can conclude with the damage control. So it's not that it's not a foolproof formula that this is the way you should do it. This type of a pattern of a fracture requires a precision and a decision on table how you should go it, but there are ways to do it. First a femur or first neck femur. But literature said neck femur is the first priority and next is the shaft femur.
Okay, colleagues. Is there any comments to this case?
Very well done. Very well done.
Yeah. Thank you very much. I mean, we have already 30 minutes past.
Yes, fine.
Actually, I prepared more cases, but I needed to stop now to allow colleagues for the upper extremity to discuss about the topics. I would like to thank you thank you for all your contributions and opinions. It was very interesting. Yeah.
Thank you, Ram. Thank you.
Thank you,
Zamaro. Thank you, Sangeet. Nice seeing you there. Thank you.
If you want to show your case very quickly, the case.
No. It's fine. It's fine.
It's fine. Okay.
It's already time. It's fine. We'll stick on to that.
In that case, may I request you, Professor Shetty, to just stay with us because Dr. Chatterjee is stuck in a traffic jam. So would you like to stay for the next session?
Me, is it?
Yes.
I'm in my OP. All right.
It's not a problem. Okay. So I'll just start Professor Gadegoni. If you are free, it's also, if you're busy, then Professor Gadegoni, maybe you can just join us because until Dr. Chatterjee joins us. Welcome to Dr. Sangeet Gawale, who is the chairman of this meeting.
Good evening, all.
Thank you for inviting SICOT, and we look forward to a interesting discussion on the upper limb. Can you see my slides?
Yes, very clear.
Okay, great.
The whole surgery from start to finish, the parts of that surgery, and then the examiner.
I don't know why my slides.
Arindam, can you excuse me? Can I?
Yeah.
Dr. Gadgoni is there. Okay.
Yeah. Okay. Great.
Thank you.
Thank you. So today we are going to discuss upper limb implantology, and our panelists are Dr. Sangeet Gawale and Dr. Chatterjee, who is not here and is replaced right now by Dr. Tadegone, Professor Inho Jion from Korea, and Mark Hansen from Germany. So this meeting, this session is going to be slightly more different. It will be a little bit more interactive. We're going to ask your opinion on how you do things. So let's start with the first case here. A 34-year-old lady riding pillion, which means that she was sitting behind her husband, fell off his motorbike, and she was wearing a sari. So I'm sure all of you know what a sari is. So this is the fracture she sustained. Now, before we actually go into fracture fixation, let me ask Mark. Mark, we have done an audit in India on our patients, and we found that most of the RTAs were from bike accidents. Now, we have a very unregulated biking system here, so I would like to know from you, in Germany, who are the principal people who have road traffic accidents? What do you see in your practice?
Very nice question, because what we see in Germany varies from what we can read in the literature. There are different patterns due to different cultures and different vehicles which are used. So first of all, what we see is that commuting in the morning and in the evening always constitutes a peak in accidents and injuries. So people go to work, they go to school, they travel to the university. So we do see certainly peaks of the trauma concerning the daytime. And then we see a varying trauma mechanism winter time as compared to summertime. So right now, spring is rising here in Munich. We had a couple of very sunny days, and furthermore, the prices for petrol went skyrocketing. So commuting to work or to school by car is more expensive. And we had such a tremendous increase in bike injuries. So bike injuries is a huge problem still in commuting in the morning and in the evening. Very interesting. Right now, we see a very high increase in pedelec injuries. Pedelecs are the electronic bikes. So what we see right now is that we have elderly patients, elderly in terms of 70-year-olds or 80-year-olds, and they, in the areas or downtown with a pedelec at about 20 or 25 kilometers per hour, and they do not have protective gear as compared to motorbikes. So bike injuries, certainly a problem. And I just want to point out that we encounter now a totally new and different entity of injuries due to bikes, due to pedelecs, because we have elderly patients, the orthogeriatric problems in bike injuries.
So Professor Inho, so what is your experience regarding in Korea? What do you see? Type of accidents? Are they bikers, or do they have other kinds of injuries? What are the kind of patients you see? You are mute, by the way.
Thanks, Arindam. Actually, it's not very different from the Germany, but I would say two peak of these fractures. One for the young guys related to sports injuries, either bike or motorbike, or the winter season is just over. During the winter season, they have a huge ski and snowboard injuries. They have all upper limb injuries. But the other group is the elderly population, because I think this is the same in Germany or India, as we have more and more elderly population, and they have all different sort of upper extremity injuries because of the trivial fall. Thank you.
Dr. Kawale, this lady was wearing a sari, and she was riding astride her husband sideways. So may I ask you, in your practice, do you find that the ladies who fall off bikes, do they have worse fracture geometry than the males who are going in the same direction as the bike. Dr. Gawale, can you hear me?
Yeah. Probably you pronounced me wrong. That is why
sorry.
I was late in making my comment. I am from Bombay. So we very rarely, we used to see that. But unlike your place, the saris, most of the office ladies, they don't wear saris. They wear a salwar or like a jeans. So the injury, what you are describing, the elbow or the upper extremity getting woven around the sari, and then they have the elbow fracture. Probably we see it very less. It used to be earlier, maybe 25 years back, but nowadays we don't see them. It is basically fall on the elbow, either as my earlier speaker suggested or commented, the two extreme age, the younger age and the older age.
Okay. So let's come to the next question. Dr. Garegone, when you are fixing a TY fracture, do you do a routine olecranon osteotomy for every case?
If there is an intra-articular extension is there, then olecranon osteotomy can only is mandatory to see the articular surface posteriorly, anteriorly. If you don't do a osteotomy, probably your vision from the anterior side of articular damage is less. Therefore, I prefer to do in an intra-articular fracture olecranon osteotomy.
Okay, so you would do it for every bad TY fracture, right?
Bad extension into the intra-articular combination. If there are only two pieces are there, I may not do it.
Okay, so can I ask Mark, do you do olecranon osteotomies for every case, Mark? Or do you do them sometimes or sometimes not?
It depends. I totally agree with Professor Garegone that if you have a simple fracture going into the articular line, you will be able to reference the condylar block and the articular surface without the osteotomy. If you have a comminuted situation with more than two pieces, it is mandatory that you actually have to open the joint.
Okay. So, Professor Inho, my question to you is, if you're doing osteotomy, what is your preferred method of closure? Do you like putting tension band wiring like here? Or do you like putting a hook plate? Do you do a tension band wiring with a screw? What do you prefer and why?
Arindam, I still prefer a tension band wiring. But I know that some of these patients, they have metal related issues later on, but still I prefer tension band wire than the plate fixation.
Is there anyone here who does it different? Put a screw or put a plate? Anyone here?
Well, I would suggest to actually differentiate again between young patients and good bone quality and elderly patients with osteopenic or osteoporotic bone. So tension band wires are not well suited for very osteoporotic bone. So as soon as we have elderly patients, we go for angular stable plate osteosynthesis following the osteotomy.
So let me come to Dr. Sangeet. Dr. Sangeet, if you're doing a olecranon osteotomy, how do you cut your olecranon? Do you do a chevron cut or do you do it different? Any other way? Any technique special?
It is a chevron through the waist of the greater sigmoid notch. And like commenting about your earlier question, what is the choice of the implant? Now, the other option, one is, as he has suggested, a plate in osteoporotic. That is a very good option. But for all younger individuals, it is still the golden standard is a tension band And how you do it is most important, because the pin migration is highest. And you have to take adequate precautions. If you don't follow, probably the pins are going to migrate. The third implant is a screw, what you said. But what happens is the ulna has a proximal ulnar deviation, the PUDA, which is at about 90 to 100 millimeters from the tip of the olecranon. So that means if you need a good screw, which will have a purchase distally, is the length is about 90 to 100 millimeters. And most often, such a long screw is not available at the time of when you're fixing or doing the osteotomy. So many surgeons, they end up putting a shorter screw, which usually migrates, and that distracts the osteotomy. So my choice, and so going back to your question, is a chevrons osteotomy, and in most is a tension band. 2-3 things are important. You bury the tip of the upper end of the wires underneath the triceps and take a tension band underneath the triceps, and your tip should engage the anterior cortex. So if you follow these 3 tips, the chances of migration or complications are lowest.
Okay, great. So this is what was done in this case. Now, I would like to ask Mark, apart from olecranon osteotomy, is there any other approach you would use for a TY fracture? Do you use a trap approach, or have you ever used a tricep splitting approach? Do you other indications where you would not do a olecranon osteotomy?
Again, if it's a very, very comminuted fracture and we need to reconstruct the articular block, I think an olecranon osteotomy is mandatory. Otherwise, I like to use the triceps splitting approach as soon as I have fracture components going very proximal. The combined medial and lateral approach is very suitable to take a closer look at the distal parts. So it very much depends on the fracture pattern, and you have to know your tools in your toolbox. And I think all the different approaches have a valid purpose in different types of fractures. There's not one approach for all.
Sure. So Dr. Chatterjee, thanks for joining us. And hello. And I would like to ask you, apart from olecranon osteotomy, which we have discussed, do you ever use any of these other approaches for a TY fracture of the distal humerus? You're mute. You're mute.
Can you hear me?
Yes,
yeah.
Make it a little louder.
Yeah, so I pretty much agree with what Mark said. I mean, it depends on the location of the fracture. If the fracture is very distal and there are a lot of osteochondral fragments, then obviously the olecranon osteotomy is the approach of choice. If the fracture is slightly more proximal and you do not have too many small osteochondral fragments, then probably a tricep splitting approach is appropriate. And the combined medial and lateral approach, well, obviously, if it's just a lateral condyle, then a coccus J-shaped approach is ideal. If it's just a medial epicondyle, then a medial approach. And in supracondylar fractures, especially in children, which is widely displaced, a grade 4 fracture, then there I like sometimes use this combined medial and lateral approach.
Okay, great. Now, this is the standard approach which most of us use. Is there just a question to the panel? Anyone uses anything different or any other variation of this? Is this okay with everyone, or anyone has any? Yeah, you're all happy with this? Okay, so we go to the next slide here. So over here we have different types of fixation, and you can see here all different ways. Now we have the principles of O'Driscoll, and I've just put them here for anyone following this. They can look at this slide. I've put it on one slide. Now, do you all, is there anyone who does any variation of the O'Driscoll principles? So let me ask Professor Inho, who is the upper limb expert here. Do you follow all these principles, or are there any variations you do, or any other way? I mean, what is your opinion?
Thanks for asking, Arindam. When you look at this Sean O'Driscoll's principle, you have to keep in mind this principle applies to parallel plate, okay? So if you like to put the plate perpendicular, this principle doesn't really apply, okay? So basically, if you have this bicondylar plate on both medial and lateral column, then you can stabilize this various internal rotation torque. And then this is very important, principles you have to keep in mind. But otherwise, if you still prefer 90-degree perpendicular, one for the medial border, posterior lateral plate, then you cannot apply all these principles. So if you read it step by step, you can really understand this. So this is only applies when you like to use parallel plate. Thank you.
Mark, any comments?
I totally agree. Well, it makes a little bit more difficult because, again, sometimes the comminution of a fracture leads you to use 90-degree plate configuration. Sometimes you tend to use parallel plates. So again, you need to know your implants, and that's why we have this beautiful session and panel discussion. But you also need to understand the principles behind the osteosynthesis.
Okay, so let's come to the second case. Dr. Sangeet, 32-year-old factory worker injured by a machine, and there were no open injuries. So you can see here a dislocation of the elbow, and there is a fracture dislocation of the proximal humerus. Here, you see, these are the pictures we have. Now, Dr. Sangeet, my question to you is, I'm sure you see a lot of industrial accidents in Mumbai. If the injury is open, are there any differences with other open injuries in microbiology, contamination of wounds? Is there any way you would deal with an industrial accident different from, say, a farm accident or from an RTA open fracture? Is there any principle which would be different? You are mute. But yes.
Probably the industry, we have to define which industry he has met with the accident, whether it contains oil-based contamination, or it is, like a crush which involves elbow or the upper extremity going in a machine and then crushing the elbow. So these are, or they have something, probably some injury where a heavy object has fallen on the elbow. So each of these three fall in a different category, and probably after reducing the elbow, yours is a simple case. Probably we can go ahead where not much contamination is there, and probably even what you have defined as an open injury, was it grade 1, 2, or 3?
No, this is not an open injury. I'm just asking you about open. This was a closed injury, and we'll come to that later. Okay. Okay. So, okay, I got your point. So you would assess the kind of the type of injury from what industry it is, and then look at the contamination. So, Professor Gadegole, I would like to ask you very quickly. I'm sure you deal with a lot of industrial accidents also in your belt. What are the medical legal issues which are a problem if you have an industrial accident? In a nutshell, how would it be different from an RTA? Do you think that the medical legal issues would be separate? Okay, I think Dr. Gadegone has left us. So I think because Dr. Chatterjee has joined. So Dr. Chatterjee, industrial accident coming to your hospital, Apollo Hospital, what kind of medical legal issues are things you have to be very careful about?
Yeah, so you see, before I joined Apollo Hospital, I was working for the Tata Sons in their steel plant hospital. So we used to continuously get industrial accidents there. I had a fairly rich experience there. You see, just one or two points I would like to mention. You see, the common injuries are either in the CNC machines, which are crushes or sometimes even amputations, typically of the digits. The other is the belt injuries, and they are very important. The X-ray which you have shown is a classic belt injury where the hand gets pulled into the belt and it produces severe traction, and that's what causes the fractures and the dislocation. Now, the typical finding here is severe internal degloving. So even if you have a closed injury, a lot of the time, the skin and the subcutaneous tissue has been completely stripped off the muscle. And once you incise this, you will discover that. And a common finding used to be that over a period of time, the skin used to blacken and necrose, and then you will have to excise the skin and you will have to skin graft it quite extensively. So these are some of the findings in industrial accidents. Special medical legal issues, the thing here is compensation. So you, especially if you are working in an industrial hospital, you are sort of between two fairly powerful bodies. The union of the workers will demand as high a compensation as they would, and the management would want to do the opposite. So you have to play your cards very, very carefully, and you get caught in the middle. So contamination, yes, usually it is grease or oil. And the bacteriology is a little bit different. In the farm injuries, you get, more of, Clostridia and Pseudomonas and that sort of thing. Whereas here, again, it's different. You get, and sometimes you can get very, very uncommon organisms such as Cytobacter, Acinetobacter, and that sort of thing you will get. So medical legal issues is mainly to do with compensation.
So this patient went to a primary hospital, I think a very small hospital or maybe a clinic, and this is what the primary surgeon did. You can see here, this is what was done. Now, then they came to us, this was revised, and a plate was put here. I don't have better pictures, so I'm going to show you some more better pictures. So you can see here a fracture. This is a different fracture altogether. Fracture philos, a plate fixed with a philos plate, and a fracture fixed with the old style clover plate. And this is a plate which really never took off. So implantology wise, since this is a discussion on implantology, let me start by asking Mark. Mark, why do you think this particular plate failed and why this one succeeded?
Well, a plate in general will support you as a surgeon to actually facilitate healing of the fracture. But the most common cause of failure in osteosynthesis is the missing reduction and the missing reconstruction of the calcar. So the plate here on the right-hand side, the top pictures on the right-hand side, you can already see that the calcar does not seem to be reconstructed. The head seems to be collapsed already. And unfortunately, the plate does not allow for modern calcar support. So more advanced or newer plates actually have a calcar support screw. So even if you have a comminuted calcar situation and you cannot really have stability at the calcar, you can try to position a calcar screw. So I would think or propose that the failure of the osteosynthesis on the right-hand side was mostly due to the fact that the calcar reduction was not perfectly, and the osteosynthesis or the plate did not allow to add a calcar screw.
Thank you. So, Professor Inho, anything you wish to add, like, for instance, the profile of the plate, the principle of locking plates? Can you just explain to our listeners the principle of a locking plate, why there are locking screws proximally and why we have cortical screws at the bottom? How does the system work? If you can explain to the postgraduates who are listening.
Okay, Arindam, I think that question is very important, and also Mark's comment on the plate is very, very relevant. I wouldn't say that the plate itself is really an issue, because we all treated proximal humerus fracture before locking plate was developed. But let's have a look. First, I would like to emphasize what is the surgical role of the proximal humerus fracture. Number one, you have to maintain the proper neck shaft angle, and you have to reposition the tuberosity in the right place. So for shoulder fixation, this is not a trochanter fracture. That's the difference between the hip and shoulder. So here in the second picture in a B, what you can see is the neck is varus deformed. Obviously, if you can have a good support in the medial calcar, it wouldn't happen. But you also have to know there is a significant varus force applied in a fracture site, as always. So how to resist this varus force? Strong deltoid will bend this fracture varus. So to resist this varus force, you need a good support in the medial side. Then this plate is not the best option. In the old days, we used to use this, but it has a lot of issues of the subacromial impingement and this varus force because it cannot resist. So a locking plate in a number in the bottom line is very acceptable, and you have done very well. But here's what I would like to emphasize again. Proximal humerus fracture, you always need to do tension suture through the rotated cuff, especially for elderly. For elderly people, sometimes tendon is stronger than the tuberosity. So you always have a circular suture around the great tuberosity and the lesser tuberosity so that it can give you additional stability. Thank you, Arindam.
Thank you. Thank you. Dr. Sangeet, would you consider putting, for a similar fracture, would you consider putting a multi-lock nail? Is it a viable option in a similar kind of a fracture?
See, the indications to me would be a third generation when you have a pure surgical neck fracture. Yeah. So here, what I see, even though the left pre-op picture is not clear, does it extend the tuberosity?
I think because we don't have a CT in this particular thing, but you know, it's possible that the tuberosity is either completely fractured or it is, you know, not it's fractured but not displaced.
And even the other the pictures, the two pictures which are on the right side, probably the D, picture D, does it show the head falling in varus? Because
yeah,
it is not enlarged.
Yeah, it is slightly varus, yes, I agree.
Okay, so probably
I'm saying as a matter of principle, I mean, I'm not talking about this particular picture. I'm just saying a similar fracture.
Right.
We can put a philos. My question is multi-lock nailing, is it a viable option in this sort of situation? Or you
right.
Arvindan, may I comment?
Yeah, let Professor Sangeet just finish his comment and then.
So if you analyze why this fracture has gone in varus, it is the tuberosity which Inho or Mark has suggested, which has not been, we have not been able to fix because we have used a nail. If you would have used anatomical plate, a locking plate, provided the reduction is anatomical, the plate will work far better, and those additional musculotendinous sutures will check in and not allow the head to fall back in varus.
Right.
Mind you, if your reduction is not proper, probably the proximal humerus behave differently, where the proximal screws, they try to converge in the head. Ideally, if you have reduced it anatomically, then the proximal screws will fan out in the head and have a purchase in all 4 different quadrants of the head, and that will give you adequate fixation. Plus, you have the musculotendinous suture through the rotator cuff to add the stability to the fracture.
Right. Okay. Good. So you were going to add something, Professor Gadegode? You wanted to add a comment?
Sir, the idea proximal femoral humerus nail, it's because actually osteoporotic bone and there are insufficient small fragments, and there is always a lateralization of the proximal humerus nail, even if you pass a entry through the articular surface. And therefore, I think that the screws, they go through the fracture site. There is no proper hold. It is only hold in the distal fragment. And even if you suture everything also, it's just a bag of bone around the nail. And therefore, though it looks a very good X-ray in the first week, after 1 month follow-up or 2 month follow-up, everything go haywire. Therefore, I think as suggested by Professor Gawale, the locking plate is a better option than the proximal humerus nail in a extended intra-articular fractures involving the humeral head.
Okay, great. Now, I think we are running out of time, so I'm going to skip the last case, and because Professor Inho is going to show us a very interesting case, so I'll just leave you with these take-home messages. The optimum placement of implants depends on patient position, surgical approaches, and following proper biomechanical protocols. So it's not just the surgery, you need to focus on getting your patient properly positioned and using the right approach, using the right way to open the fracture, and attention to these basic details will aid proper fixation and optimize the results. So I think Professor Inho is going to show us a very interesting case. He's an upper limb surgeon and he has a PUDA case on PUDA. So I will stop sharing right here, and the last 10 minutes of this panel discussion will be taken by him, and he will show us an interesting case.
Thank you, Arindam. And since we have a limited time, I'm going to share quickly my case. Okay. So can you see my slides well?
Yes.
So this is a 25-year-old medical officer had a ski injury of elbow. And as you can see, this is a very typical bottle type Monteja fracture dislocation. So I think all will agree that we need an anatomic reduction for proximal ulna. And I double checked this radial head is congruent to the capitellum. You agree, guys?
Yes.
Okay, this is the intraoperative finding, and my resident the next day called me that, Professor, we have a trouble. So you have any idea why this had happened? Dr. Mark, you have any comment why we have this phenomenon here?
Did you check intraoperatively during the first surgery for additional intra-articular injuries or capsular or tendon injuries?
Oh, that's a very good point. Yes, I did what I did on the lateral side repair. So I cut this annular ligament. So I double checked that there's no soft tissue impingement. Mm-hmm. So there might be a two suspicion, whether any soft tissue impingement in between or the reduction issue. So any comment, Dr. Sagrit?
Yeah, that's me. Probably if you have not achieved the length of the ulna.
Mm-hmm.
Okay. Or what I do is in such Montegia, I pre-bend the plate to get an additional length of the ulna. say maybe by a millimeter or two, I pre-bend it so that, the head reduces and it is stable in rotation.
Thank you very much. That's exactly what I was going to say. So I will. So this is the triggering point because what we used in this patient was anatomic plate from the big companies. So these are 3 types of anatomic plate. None of these, if you apply to the sawbone, that does not really fit to the proximal ulna, because the proximal ulna is not the straight bone. That's why here I would like to say a proximal ulnar anatomy. You have a varus dorsal angulation, which has been already coined many years ago. So we have done some CT study. You see, there's an apex which has a dorsal varus angulation. As Dr. Sangri said, this is what people say a PUDA, proximal ulnar dorsal angulation. So if you do not really appreciate this PUDA, sometimes complication happen. So dorsal angulation about 5 degrees, 5 centimeters from the apex of this olecranon. So let's have a look. This anatomic study clearly shows that you need to really appreciate this PUDA in a proximal ulnar. So this is a little bit of mathematics. So if you do not really appreciate this PUDA, there's a higher chance of radial head subluxation. So gentlemen, again, I would like to emphasize this photo. None of the anatomic plate really reflect the anatomy of the ulna. But I was surprised to see that if you look at this instruction of the plate, they already mentioned that original human bone is different and you need to reflect the anatomy. So you need a little bit of a bending here, especially when you have a very comminution and a proximal ulna, then there's a very higher chance that you can encounter my complication, which is very rare. So Dr. Arindam or Mark, you have any comment?
Yeah, I have a comment that these proximal ulnar hook plates, for some reason they're not very long. So if you ever have a fracture which combines kind of a lower olecranon fracture with an ulnar shaft fracture, then you are kind of caught, you're in trouble because your plate may not get the second fracture. And in such situations, we have actually used recon plates, which we have mechanically bent and used it like a hook plate, but it is not a very satisfactory device, but you can bend it medial-lateral and you can bend it a little bit like a hook, but it's not an ideal situation. So I don't know why they don't make them. I don't know if they're available now, but certainly my experience is that they're not very long.
Okay, we are not using recon plate for elbow anymore, but I think I will keep in mind your comment. Dr. Mark, any comment?
Yes, I just want to ask the question because when we see this kind of complication here in Munich, what we do is we use contralateral X-ray to look for the intra-individual anatomic variations, because the PUDA angle is very different from one patient to the other patient. So in your practice, do you use the contralateral X-ray in these cases to assess the axis and the variations?
No, I didn't check on the opposite side because it was a very frustrating situation which I never had before in this case. So yeah, I think that's very relevant. When we have done a CT study, your comment is really true because there's a huge individual variation in a PUDA location and the angle.
Okay, I think that was a fantastic case, and I think we will end this session here. I just asked Dr. Sangeet, as chairman, do you want to make any comments? Any comments about any of the any aspect? Because we are looking forward to more joint collaborations between SICOT and WIROC. So you or Dr. Sham, if you want to say any comments, or just we can just close it here.
Yeah, that was an excellent session on how to use the implant in different situations. And probably all 4 or 5 of us can agree that these are specific implants. And even though we use the same implant across the world, but still the anatomic variation, as Dr. Ino has pointed out, or Dr. Mark has pointed out, it varies from country to country. So probably my suggestion would be for each continent, the implant would not be the same, since our Asians population are different anatomically a bit as compared to what the implants we are getting.
Okay, Dr. Sham, any further comments? Otherwise, we will finish here.
I'd just like to thank SICOT and the entire board for participating in WIROC Global.
Arvindan, congratulations.
Thank you.
Yeah, special efforts of Dr. Arindam for organizing this and getting all the faculty on board today. So thank you very much, sir, for this great effort, and thanks the entire SICOT board for this effort. Thank you, sir.
Okay, Roman, any comments before we leave?
Just a couple final words. I would like to thank everybody, and Rindam for this organization. It was perfect, and would like to thank everybody and see you next time.